Great, thank you. I'm just going to share the slides. Hopefully everyone can see that. Great, okay. Hello everyone, my name is Marlene. I'm a registered nurse from Ottawa, working as a research associate at the University of Ottawa with my supervisor, Dr. Patrick O'Byrne, who's here today as well. I previously oversaw a safer supply program in Ottawa for a number of years before moving into this research role. And so today myself, Patrick, and Athena will be discussing the results of a Safer Supply Ottawa program evaluation that we've completed over the past few months. So there's going to be a few components to this presentation today. So first, Athena is going to talk about the results from ongoing chart reviews of the 425 participants who are part of a Safer Supply program in Ottawa. And then I will speak about the qualitative research that I completed with Dr. O'Byrne this past summer. And with that, Athena will start.
So I'm Athena. I'm also a registered practical nurse, and I also used to work at the ground level of the clinics at the Safer Supply group in recovery care here in Ottawa. Now I complete this research and collect it from the various sites and then put it together in data form for us to share. So this data is collected from our last 4-month period, which was April 1st, 2022 to July 31st, all inclusive of those 4 months. And it includes participants from all 3 of the sites, which for us in Ottawa is Recovery Care, Somerset West, and Ottawa Intercity Health, for a total of 425 participants on the program. So by program type, there's a bit of a little small difference. So we have the Safer Opioids program where people are prescribed an opioid. We have 25 on the safer stimulants and 119 on the combination, which is people who are on some sort of prescription for a safer opioids and a safer stimulant, for a total of 425 participants. So this is a small breakdown of the different programs. The safer opioid supply is for people who are having a replacement of the illicit opioid supply. So they're prescribed an opioid. The safer stimulant supply is the exact same idea. It's people who are provided a replacement for the stimulant supply. And then the combination, as I just said, is people who are on both of the programs, targeting both a safer opioid and a safer stimulant to meet all their needs. So this is some demographic information that we got from the 425 people. The median participant age is 40, with the youngest being 21 and the oldest being 71. It's 66% males on the program and 34% females. 94% of services received are in English here in Ottawa. And then our ethnicity is a little bit widespread with, sorry, I can't read the slide because what this is, 70.9% being white, 14.6% being First Nations, Métis, or Inuit, and then 11.7% being sort of a breakdown of others ethnicities as well. 2.7% were unknown or just unreported for the 425 people. Okay, so this is some of our fentanyl use trends. So this is a combination of both the safer supply opioid and combination supply specifically for their fentanyl use. So 70% of people, or 280 participants, reported either a decrease in use or no use at all during this period, whereas 15% reported the same level of use, sort of a stable dose throughout this period, and 15% of people reported an increase in their use. But overall, between the 2 programs that target fentanyl use, we saw a 70% decrease in use. Separated by gender, there's small differences, but very similar trends were reported by participants across gender. Slightly more female participants reported an increase in fentanyl use than compared to their male counterparts, but overall, still close to that 70% mark of people reporting a decrease in use throughout the genders. This slide is specifically for the opioid supply, so that's our 281 people who are on just a safer opioid. We saw very similar to the main results, 70.1% of people reported a decreased or discontinued use of their street use. 16% of people reported that stable increase, or sorry, same dose, and then 13.9% reported an increase. So again, consistent with sort of the previous slides. Okay, this is again separated by gender. Similar trends across genders. We saw very close to that 70% of a decrease or discontinued use over the 4-month period, with minimal difference between the genders for the other different breakdowns, just same or increased use. Okay, so moving on to the combination safer supply, representing 119 participants. Most participants reported an overall decrease in both fentanyl use and stimulant use. And of note, more participants reported the same level of stimulant use in comparison to reported the same level of fentanyl use. So there does seem to be still a little bit of a difference there. Overall, the overwhelming trend was still a decrease in use for both substances being studied on the program. Okay, also another breakdown by gender. So we saw an overall trend of decreasing or discontinued use across both genders. Female participants reported a slightly higher decrease for stimulant use compared to decreasing fentanyl use, with male participants reporting the opposite. Overall, still very similar numbers in terms of their decreased or discontinued to same or increased use, with sort of that decreased or discontinued use being the most reported trend for patients on this program. Okay, so this to explain is the relationship between each individual participant's concurrent drug use. So their reported fentanyl use and their reported stimulant use. So each sort of bar here, each individual's use, not the overall use of the program. And 53.8% of participants reported a congruent decrease in both types of drug use. 10.9% reported decreasing their fentanyl use while maintaining their same level of stimulant use. So overall, that means 71.4% of people experienced an overall decrease in their substance use, regardless of sort of the two different ones that we're studying here. So that's was great to hear from our participants on combination supply. So this represents participant data from the safer stimulant supply. So 25 of our participants, or 5.9%, are on a safer stimulant. The majority of participants reported a decrease in their stimulant use, with 60% of participants stating that they decreased their use. Of note, more participants reported the same level of use compared to the same category of other safer supply program types. We do have a smaller group with only 25 people in this program so far, and we're seeing that still develop, but overall the 60% of participants still stated they had a decrease in use during this period. This is the stimulant trends by gender. There is a noted difference in use trends between female and male participants. Female participants reported an increase in stimulant use. 75% of females reported a decrease in use. 41.2% of male participants reported the same level of stimulant use, while 52.9% reported a decrease. So this is the slide where we saw, or sort of the group of people where we saw the biggest difference between genders. It's our group with the smallest cohort of people as well. But we still saw the majority of people reporting a decrease in use overall. Okay, so lastly, this is a slide recognizing the overdose events that our program participants experience. So this is just a study of people who reported having overdose events at program intake. It's essentially a study of the same people who said, I am actively overdosing, starting the program, and then studying them now and seeing what their use is like and if they're still experiencing those events. So at the beginning of the program, 100% of these people were experiencing overdose events. At this point, in this 4-month period, only 19% of those participants continue to report experiencing an overdose event. So of importance, 81% of these participants reported no overdose events during this check-in reporting period of the entire 4 months. So in summary, 4 out of 5 of the participants studied here did not experience an overdose event for the entirety of this period.
Amazing. Thanks, Athena.
Yeah.
So now that Athena has finished speaking about the broader program data, we'll begin exploring the second component of the program evaluation that I had mentioned earlier. So we completed qualitative research to speak with Safer Supply participants about their experiences on the program and how the program may have impacted them. So we recruited 30 Safer Supply participants to complete a survey and semi-structured interview with us. So within the survey, we asked about demographic information, as well as more in-depth questions related to their ongoing substance use and previous substance use. The surveys took about 5 to 10 minutes to complete with each person. Once the surveys were completed, participants then did a semi-structured interview with me, which took about 15 to 60 minutes, depending on the person to complete. Interviews took place in a private space at each of the different program locations. The prompts for the interviews were created prior to the interviews to ensure we did touch on specific topics. However, participants were encouraged to really guide the conversation in the direction that they wish to really capture their personal experiences. All of the interviews were audio recorded to make sure that we had really accurate transcription to be able to look at. The core interviews were initially conducted at a single location, which was Ottawa Inner City Health, followed by Recovery Care, and finally Somerset West Community Health Centre. And overall, we noted that participant responses and data collected were consistent across sites. So we were happy to put the 3 sites together and look at them as one group. And the participants were paid $100 cash for their time and expertise. So before we take a look at the survey data and then the interview data after that, I just wanted to provide a really brief breakdown of the participants from each Safer Supply site in Ottawa that we spoke to. Just a reminder, this is different than Athena's data, which looked at everyone on the programs, and this is just, of course, a subset of people. So we had 14 people from Recovery Care, 12 people from Ottawa Inner City Health, which exists in a shelter, which within that there's a supervised consumption site. And then 4 people were recruited from Somerset West Community Health Centre. So the participants that we spoke to were a median age of 42, with the youngest being 28 and the oldest being 67. Participants had been on Safe Supply for a median of 21 months. We did have some participants who were newer to the program, with the shortest amount of time being 2 months, and some who had been part of it since the inception of Safe Supply in Ottawa, with the longest being 36 months. So we did try and get a good mix. We were able to speak to 13 women and 17 men. Almost everyone we spoke to was born in Canada, and the majority of participants reported their ethnicity as white at over 50%, followed by Indigenous at 30%, and so on, as you can see on the slide. Most people that we spoke with reported their sexual orientation as heterosexual, and the majority of participants reported they completed less than high school as their highest level of education. Everyone that we spoke to spoke English, and only 50% said English was their only language that they could speak. We did ask participants about their lifetime drug use. So in your life, have you used, and then we went down that list of drugs you can see at the bottom. And as you can see, the use of cocaine, fentanyl, other opiates, crack cocaine were most commonly reported by people. The median age that people reported starting to use any drug at all was 13 years old, with the youngest being 8 years old and the oldest being 42. The median age when people first started to use opioids in particular was 22, with the youngest being 12 and the oldest being 60. Everyone that we interviewed was part of a safer opiate supply program. As you saw from what Athena presented, safer opiate supply by far holds the largest number of people on it. And the safer stimulants is a much smaller group. However, 8 of the 30 people we spoke to were also part of the safer stimulant program. It was interesting as well to note that everyone was on some form of a long-acting opiate to help manage their withdrawal symptoms. Many participants that we spoke with anecdotally said that hydromorphone alone was not enough to manage their withdrawals and cravings. So you can see that the most popular was the 24-hour slow-release oral morphine, or what most of us will know to be Cadian. Within this kind of group of people, that was the most common. We did ask about substance use complications, specifically prior to starting Safer Supply, so things that they experienced before the program. Everyone that we spoke to reported having some sort of complication, if not many from this list. Legal issues and criminal activity were the most commonly reported, followed by frequent overdoses, hospital visits, and so on down the list. Drug use locations. So similar to lifetime drug use, we did ask about where people have used drugs in their lifetime to get an idea of what was most common. So supervised consumption sites and at their own house or at a friend's home was the most common. We also asked largely for the interest of the Ottawa group, but interesting to note here as well, which supervised consumption site they use of the 4 that are currently available in Ottawa. And Ottawa Intercity Health was the most common, followed by the Sandy Hill Community Health Center. So getting into pre-post self-reported measures for participants, we felt that doing something like this was really important for the program to see how Safe Supply might be impacting these different factors that we're going to discuss. So for example, with mental health, we asked people to rate their mental health on a scale of 0, poor to 5, excellent before they started Safe Supply and then after. So they had to think back, of course, for before and then give the answer of after for that like current time. So before Safe Supply, participants reported a median mental health score of 1.75. And after Safe Supply, or currently, participants reported a median mental health score of 3.75. We did the same thing with fentanyl use. So we asked people to think about their fentanyl use before they started and after or currently. So before Safe Supply, participants reported using a median of 10 points a day. And after Safe Supply, participants reported using a median of 1.5 points a day. So again, pre-post, so for housing, before Safe Supply, most participants reported they were staying in a shelter, 22 out of 30 had said that. And then if you look at the graph for after, the number of participants in shelter shifted to 14 of 30. The number of people with housing or who were housed increased. And many people that we spoke to anecdotally reported that Safe Supply supports and stability really helped them to be able to meet this goal of getting housing. Income source, what I think is of note here is that many more people report to be on ODSP in the after chart that you see, which is important because participants on Safe Supply would be eligible for ODSP should they want this, given a diagnosis of opiate or stimulant use disorder, depending on what kind of program they're on. So seeing people be able to get the supports that they deserve, should they want it, was a great thing. So again, pre-post for this, the changes here are quite striking, so we'll walk through them. For overdose events, 28 out of 30 participants that I spoke to reported an overdose event, experiencing an overdose event prior to Safe Supply, and only 6 reported experiencing an overdose ever since joining Safe Supply. As for legal issues, a similar question was asked, and we went from 28 people who reported legal issues before starting the program to 12 reporting after. Something I really want to point out is that these graphs don't demonstrate the scale of change for some people or the nuance here. So for example, some participants reported going from overdosing every day before Safe Supply and then have only ever overdosed once since. Or some participants reported participating in many criminal activities before Safe Supply, for example, theft, fraud, drug dealing, assault very frequently, to since being on the program only reporting having participated in dealing fentanyl when they absolutely must. So that's a pretty big change that isn't necessarily captured by this slide. Before we jump into, I don't know if now is a good time, Rebecca, but before we jump into the kind of second part of interviews, is now a good time to do the
Sure. Fola, are you able to do the poll for us? If people could quickly complete this poll, it's really helpful for both the Ottawa Safer Supply Program and for the community practice. Thanks. You can continue on, Marlene. Thank you.
Sure. Yeah, no problem. So that was the survey data that we just looked at. So the just quick 5 to 10 minutes piece that we did with the participants. And now we'll jump into kind of the main portion, which is the interview results. And we'll spend a little bit of time here. So from the interviews, we had 3 themes that came or that arose. So the first one was the context of substance use. So people really wanted to talk about what was happening in their lives before Safe Supply, but also the context of the present day as it relates to being a person who uses drugs and what that topic or what that is like. This can include topics or will include topics like trauma, the structures of violence faced by people who use drugs, the cycle of drug use, and so on. Process, you can see is program process is the second interview theme. People spoke about presently what it was like being a part of Safe Supply, what that meant to them. And then the third piece, envisioning the future, people spoke about kind of what they want to see with the programs, how they might want to see them evolve and change, and the future that they envision for themselves. So we'll go through each of these larger themes one at a time, explore what they mean, and make sure we really capture what the participants were saying. So the first theme, the context of substance use, participants spoke at length about the importance of understanding the broader context of their substance use. So things like their own personal history, their current experiences of structural violence, if that impact their mental health and well-being. Within this larger theme, there were 3 sub-themes of trauma, the cycle of use, and previous supports that participants spoke about, and we will go into each of these 3 now. I thought that this quote really captured the beginning of this section really well, so I'll read it out loud for everyone. One of the participants said, quote, "Because opiates helped me not to think about a lot of the trauma that I went through, and I went through a lot of trauma. I was on the streets when I was 15, run away from Children's Aid, being physically, sexually, mentally abused by my foster family. The reason I use opioids is to forget and to not think about that." For me, this was really impactful. This particular participant spoke at length about their experiences being a child and then a teenager and then a young adult, being in and out of psychiatric institutions on a weekly basis to the point that the staff all knew them by name. And they disclosed that once they started using opiates, the cycle of moving in and out of mental health services stopped, that opiates were the medication they needed to manage their complex trauma. I found this to be really powerful and wanted to start with this quote before we jumped into everything else. So the first sub-theme that was mentioned was trauma. So people spoke about feeling rejected and abandoned in their day-to-day life, both before Safe Supply and now being a person who uses drugs. So one person said, quote, "I walk down the street and I'll see someone overdosing on the sidewalk and people are standing around taking pictures of them and laughing. And I'm sitting there trying to save their life. But it's life, right? It's not going to end anytime soon. It never will." The end result of this is that people spoke about avoiding much of society as they don't want to feel judged. They often feel dehumanized, as though people are just looking at them to look at their substance use and not see them as an entire person. One participant said that they felt categorized as, quote, "just another junkie." No, I'm someone's child. It could be someone's sister, brother, mother, uncle, whatever. It's somebody. People also described feelings of powerlessness in their life before Safe Supply, as well as extended periods of blackout associated with their substance use, which left them kind of feeling like they didn't have any information about what was going on during those periods in their life. One participant said that life felt, quote, "chaotic," definitely chaotic. From one day to the next, you don't even know what's going on. So with the illicit drug supply constantly changing, people spoke about the fact that you never really know what you're going to get, but you also feel like you don't have a choice because you need to manage your dope sickness. And so you end up going back to the toxic drug supply to be able to do this. And then people also spoke about guilt and shame. So they spoke about feeling embarrassed or ashamed of their drug use. Although particularly people spoke about the criminal activity they had no option but to participate in. They expressed how they often look back on this time in their life with remorse. So one participant said, quote, "I didn't like participating in crime, but I had to do what I had to do." So this is just trauma continued. People spoke about feeling of hopelessness, so having very limited decision-making ability surrounding their substance use, feeling like things were out of their control. They also found it very difficult to conceptualize the future and spoke about living day to day and struggling to form goals. One participant said, quote, "I really didn't even care about dying because I didn't think there was a way out." Unpredictable was another kind of topic that came up often. People spoke about that buying illicit substances felt like Russian roulette. We actually had a couple people use the term Russian roulette with us. Someone said, quote, "You can't just stick with the same average amount. That could be like 10 times stronger than what you were doing the day before." So this was associated with really, really intense fear and constant worry. One person said, "I just take the chance every time I push the needle." And then finally, on this slide, we have constant loss and grief. So people spoke about cumulative grief, a really large volume of people dying in their lives over time. One participant spoke about losing hundreds of people. Another said, quote, "I think about how many friends I've lost in the last couple of years, and 25 is a high number to lose in a year and a half." People also experienced disenfranchised grief, where it was a complex form of grief that was often pushed under the rug within larger society and not accepted. Individuals also experienced loss in their life through being an overdose responder and having to continuously bear the burden of responding to their friends or their peers or people they find that had overdosed because of the toxic drug supply. One person said, quote, "To actually watch somebody drop, turn gray, turn cold, turn blue, it scares me." So the next sub-theme was the cycle of use. This was very prominent within the interviews. People spoke extensively about not having any time to stabilize themselves before safe supply. They described a lack of control over their days and the constant experience of withdrawals and cravings. One person said, quote, "Everything seemed impossible at the time just because my sole purpose in life was to stay unsick or to get high." Another person really described this cycle quite well when they said, quote, "Well, you get up, if you had money, you were going searching for the drugs, you get the drugs and then you do them. As soon as you're done doing them, you're looking for money again for your next hit. And it's a cycle the entire day. It's hard, it tears your soul apart." Within the context of safe supply, the participants discussed that it was a tool to interrupt this cycle and try to regain some control over their life and their time. So someone said, quote, "With safer supply, you're not sick. So you're not sick of being sick and you're not chasing the next high. You have time to actually go see psychiatrists and make doctor's appointments and find out the real reasons why you're using drugs." And then finally, the last sub-theme is previous attempts to access support. So people spoke about past experiences accessing support, specifically with regards to their substance use. And these were the most common three that were brought up by people. So with detox, people had varying experiences. For some, this was a place they could rest and recover when they were ready to do that. So one person said, quote, "I would crawl to detox and I would sleep on their front porch and I would say, 'Wake me up when you have a bed.'" For other people, detox was not as impactful as ultimately they just didn't want to stop using opioids and stimulants. They wanted to continue their drug use, but safely. So one person said, quote, "I like doing the drug. They," meaning detox, "wanted total abstinence and I just couldn't do it." The next item listed here was self-imposed detox. So just a few participants reported doing things like locking themselves in a room to try and stop themselves from using opiates or trying to abstain on their own and how difficult this was. And then finally, the most commonly discussed substance use support previously accessed by participants was opiate agonist therapy or OAT. Overall, many of the participants we spoke with were unhappy with the side effects, particularly with regards to methadone, and didn't find it impactful for them. People described it as something was missing for them. So one person said, quote, "I didn't enjoy it. It didn't make me feel normal." People also described not feeling comfortable with many OAT programs. So a couple people recounted times they felt judged and stigmatized, that they didn't find the protocols and policies around these different programs suited their needs as they were too inflexible. So one person said, quote, "You feel so judged walking in there right from the get-go. They make you do a urine test twice a week. And if you use illicit drugs, they're throwing it in your face. Use anything and we're kicking you off the program. It's a stressor. So it's easier to just go get high. Why deal with that if you don't have to?" So the second broader theme was about the process of the Safer Supply program. So many participants, of course, spoke up with me about how things have changed with them since they have started Safe Supply. The vast majority of participants had really, really positive things to say about the program, though they also shared barriers, and this was something we purposely did bring up with people. We reviewed logistics of the program as well, the experience of starting the program, what check-ins are like, and so on. Interestingly, over time, we saw this theme come out of a process that I think that many of us see in our clinical work, where someone doesn't just start a program and immediately buy in or find success with it. People need time to trust, to build respect, to build rapport, to get used to the program, to get used to a new routine. And this really speaks to the fact that we need to expect that people will miss pickups of medication. They might fall off the program, they may get frustrated, and they might struggle. But that overall, the important thing is that the program is there for them when they are ready for it. And it's okay to leave or miss a pickup, that they can be restarted and brought back into the program. I will say that overall participants felt really intense connection and community from the different Safe Supply teams. So we'll get into these different items now. So to start, we'll look at program logistics. So we spoke to people about program referrals. Most people were referred by peers or other people who use drugs. This is really important to note because this is how we facilitate the referral process and how we build trust. Nobody said, I joined because of this nurse that I really liked, or because of this healthcare provider I really liked. Like, usually in the programs over time, trust with those providers was built, but it was peers and people who use drugs who were the real kind of drivers of encouraging others to join. Starting the program, everyone had a different reason and a different motivation that drove them to want to start. People also spoke a lot about feelings of happiness at being accepted into the program. Here in Ottawa, we have a limited amount of spots to be able to offer, although we do have quite a vast number of people on the program. There are limits to everything, and so many people just spoke about feeling really excited and happy to be starting. Participants had very little to say about the intake process. Most described it as fairly easy and straightforward. And then as for goals, most people did report an initial goal, of course, of wanting to decrease their illicit drug use. Though of note, many had other goals, such as you can see on the slide, someone talking about wanting to see their children. And importantly, goals changed over the course of the program. Check-ins were discussed as a time to reconnect and review goals. Participants really liked that they felt the team had buy-in to their life, that it wasn't just about their drug use, it was about them as an entire person. For the environment, people found the different program environments to be quite friendly, welcoming, and non-clinical. The way things are set up in Ottawa, as we've discussed, there's 3 different programs and they're all in 3 different kind of types of areas. So there's the one program in a supervised consumption site within a shelter, another that is a clinic, like a clinic you can just show up in walk-in clinic. And then the third is from a community health center. So they're all quite different to suit different needs. And people spoke about how it was already part of their community and places they go. So that was helpful and made it easy for them to kind of integrate it into their life. Participants spoke about being able to trust and depend on the team they work with over time and described a feeling of unconditional support. As well, participants really liked the wraparound supports that were available at each different location. They found it really easy to get access to things like primary care, housing services, and it was really convenient to not have to go to multiple different places to get care and services that were needed. So next we'll review some program concerns, which of course are really important, and it's how we improve programs. Some participants did find the Safe Supply programs to be restrictive, although this varied depending on which of the 3 programs they were speaking about. So some of the programs had witness dosing, which a couple of people struggled with. All of the programs or most people were on daily pickups of medication and weekly check-ins, and some were on weekly urine samples. And so kind of the day-to-day needing to go check in was quite difficult to be able to get your medication, as well as the weekly check-ins. And so that's something that the teams have noted. Inadequate drugs. So we'll talk about this a little bit more in theme 3, but participants had found that the max hydromorphone dose was not enough, and that hydromorphone in general was not enough. People wanted different drugs to match more closely the types of illicit substances they were using. And then finally, diversion. Diversion was purposely brought up with participants, as we know this is a very commonly discussed topic about Safe Supply and within the Safe Supply community. Participants generally talked about not approving of others participating in diversion, and some agreed that it was definitely happening. Participants did bring up a number of really good points. A couple of them talked about the fact that even if diversion was occurring, it's much safer to get hydromorphone than it is to buy illicit fentanyl. People also spoke about the fact that sharing is a very normal expectation within the community of people who use drugs and a form of caring for one another. It's not unique to Safe Supply or hydromorphone tabs or anything like that. People just take care of each other when that's needed, and that's kind of just an overall piece of their culture. And overall, people spoke about the fact that diversion will happen whatever the program is for substance use, and that they didn't feel it was unique to Safe Supply. So we've covered program logistics and concerns, so we're going to move on to benefits now. So quote, "They don't judge you and they accept you for who you are, however you look. If you didn't wash your shower, they'll offer you shower facilities. They'll offer you something to eat. They just make you feel comfortable. They accept you for who you are." So this is just a really brief slide to see the many different benefits that we are going to move through. So people spoke about a deep sense of community that they had from being part of a Safer Supply program and the environment provided by staff. They spoke about feeling accepted, welcomed, like they were part of a family. People felt a great connection. They felt that they were engaged in the process of the program themselves, of course, but also felt like the Safer Supply staff were engaged in their program too, and really bought into their success and wanting to see them succeed in the ways they wanted to. They found a lot of connection with programs also who had peers readily accessible, and peers often served as a source of inspiration. People didn't feel like they had to hide who they were. They felt they developed trust and respect with the team, and that they could confide completely in the teams when they needed to. And then as well, as I mentioned previously, people were really grateful to have been selected to be part of Safe Supply, and many people, of course, described Safe Supply as life-saving. So in contrast to the hopelessness that was discussed in theme 1, of people kind of spoke about that as prior to Safe Supply, people now described a feeling of hope in their life. They've talked about being able to see the future more clearly and being able to lay out goals for themselves. Because consistency was really important. So knowing exactly what's in the medication being given to you, gives you a lot more control over your substance use and relief in knowing what you're getting. And then safety, people felt relief as well with no longer needing to participate in criminal activity to manage withdrawals and cravings. And knowing when and where medication could be accessed next alleviated a lot of anxiety and made withdrawal symptoms less difficult to manage. Having a routine and structure built into their daily life was really, really helpful for many people, again, to interrupt that cycle of use that we talked about earlier. People spoke about having more time to be able to spend doing other things. with this support and stability, like making doctor's appointments, seeing family. And then finally, autonomy. People spoke about having more control over their time as well as control over their decision making. Participants also described in their interviews decreases in their criminal activity, decreases in their substance use, and improvements to their health and well-being. This was very similar to what we got from the survey data when we spoke to them. So the process of being part of a safe supply program and what it offers a person over time. So we'll go through to look at to see what this looks like. But people really spoke about the fact that it's not a linear path. And this is the reason why safe supply is so impactful for people, because they can go on and off, and they can each make their own way and kind of guide the program in the ways that they see fit to make it work for them. So first was individualism. So people felt like they were looked at as an individual, not as a single rigid set of guidelines that they had to stick to. They felt like they were treated like an entire person and that they weren't just looked at as somebody who uses substances. So people spoke about feeling more normal as time went on in safe supply, things like being able to re-engage in activities that they really enjoy. People did sometimes speak about being at a loss of what to do with their time now that they were moving away from that cycle of drug use. And safe supply did really help to structure this. People spoke about being able to come to safe supply at different points in their life with different goals, and that the program could really be made to fit what they needed at that time. They felt they had lots of different options to check in with their teams, and they had confidence that they wouldn't just get cut off or reprimanded if they forgot to check in or forgot to pick up medications. They knew that every effort would be made to be able to make sure that they get their medication. People did talk about the struggle of the program though, which is really important to note. So people struggle with their tolerance. They struggle with new relationships with staff. They struggle to build trust. And the fact that it can take a really long time to feel that the program is helping, and that it's really important to offer people this time to make sure that they have this time to kind of acclimate and get used to the program. And then finally, repetition was brought up by participants as well. Things like needing to be restarted on the program, or people making progress within the program and then leaving. But knowing that when they came back, they would be welcomed. And the fact that it's really important to understand that this is normal and in fact expected. It's just really important to welcome people back with open arms so that they can confidently come back to the programs when they're ready. So the last theme that people spoke about was envisioning the future of safe supply and what they would like to see happen. So everyone was asked about what it would mean to them if safe supply was no longer an option, such as when spots fill up, or the fact that it's not available in many cities or towns, or that there is a time limit to funding for programs. Participants had very, very intense reactions to this. Some cried, some yelled. People spoke about the fact that they couldn't even imagine this happening. It was too difficult. This really speaks to safe supply being an essential program, an essential service. It wasn't just about the drugs, however. In fact, a lot of what people spoke about was the environment, the teams, the connections they made, feeling accepted and feeling cared for. Some people even spoke about if programs closed, really being worried about what would happen to the staff, or being worried about their peers and other people who use drugs and how they would ultimately be the ones to suffer. So for the future of safe supply as well, people spoke about consistency in care. So safer supply care can be very disjointed currently. Individuals spoke about feeling judged at pharmacies that were not familiar with safe supply, being questioned by pharmacists or other staff members about their prescriptions, even when they had been on the program for a really long time. People spoke about the intense frustration at jails not providing safe supply medication, despite it being their prescription medication. They described intense struggles with getting medication when they were in the hospital, and how this made it really, really difficult to be able to access hospital or urgent care when they really needed it. And then finally, people also spoke about being really concerned about what their primary care provider would think, and if they might judge them, or if something else might happen. So one person said, quote, one person said when talking about not being able to get their safe supply in jail, they said, quote, "There's no reason why they can't just give it like the pharmacist does. It's not that hard." Another person spoke about kind of all of these different things, although particularly jail, hospital, primary care. They said, quote, "If you're being prescribed something for your mental health or your physical health or whatever it is, I don't think that any private institution or government institution or anyone should tell you that you can't do this anymore. At this point, it's my medication." So when considering the future of safe supply, people spoke about wanting to see more education and awareness for the public. Stigma and marginalization is still very central to their lives, and occurs on a near daily basis. They would also talked about wanting more education and awareness for their own community of people who use drugs about what services are out there. So for example, phone lines that people can call, the overdose prevention phone lines that people can call. Some individuals didn't know about that, and said they would be really interested. And so getting the word out there to them was really important. Increased program access. So people spoke about feeling frustrated regarding the lack of portability with safe supply medication, because it is very limited to where you can, it is very limiting with where you can live or what you can do. They were worried about the availability of services for other people who may need it. And then finally, people spoke about expanded drug options. So individuals were asking for things like injectable fentanyl, injectable heroin, increases to the maximum hydromorphone tabs that were available, more safer stimulant spots to be available. And overall, people really just wanted to match the drug that they were using. So if they were using illicit fentanyl and injecting it, they wanted to be able to have pharmaceutical grade injectable fentanyl. They just wanted to match the drug being used. Participants were really eager to advocate for themselves and their community. They wanted other people to know how life-changing safe supply has been, all of the benefits that it's brought to their lives. And so we spoke to them at length about this. So there's a couple quotes on the slide there that speak about it being really life-saving, that it helps to stop crime, and that it helps people's lives and well-being. There we go. Here are some more quotes. So people spoke about that safe supply is more than a Band-Aid solution, and that when someone's sick, you need to take care of that illness first. Another person spoke about that a safe supply is important for all communities and expressed a lot of concern for the future of people who use drugs, particularly in communities where safe supply is not available. And then the person on the far right, you can see, was speaking about really feeling as though those with decision-making power are often out of touch with the reality of illicit substance use nowadays. And then finally, this is kind of the last group of quotes. People spoke about safe supply, and that it should be considered an essential medication and an essential piece that can be offered to anyone who uses substances. And that safe supply for many people is helpful for meeting all sorts of goals in their life in general. So the last main thing that we're going to talk about before we can start answering questions is we're going to spend a little bit of time on this slide. So this framework came about from the interviews that we did with participants. We sat down and created this based on what we were told. So if you look through the middle, as people who use drugs move across their lifespan, they really clearly describe their substance use as a cycle. So if you see the top orange arrows or the top orange cycle of arrows, this really represents the day-to-day struggle of managing substance use alone, whether it's the cycle of using drugs, the finding, buying, using, repeat, but also when people try to independently alter the way that they're using or trying to stop using drugs. For example, we spoke about self-detox earlier. The orange cycle is smaller because it's rapid and ongoing, with a lot of chaos that often comes with a lack of support, which is what they've kind of told us about. The bottom purple cycle is larger, and this cycle is about accepting and using support for substance use. People spoke about it's larger because often accessing support it doesn't always, but it can slow down the chaotic cycle of substance use. Participants spoke, for example, extensively about how the intervention of Safe Supply helped to lessen the chaos in their life and assist them in regaining autonomy and control. Of note, the little green block is Safe Supply, but it doesn't have to be. For many other people that we didn't speak to, we know that accessing things like rehabilitation services, OAT, would also help them to be able to slow down their cycle of use. And so you could really put any of those different programs within the green box that's attached to the purple cycle. And then surrounding this, we have the past and current experiences of trauma that permeate people's lives, as well as the context of substance use and how that impacts someone, such as the experience of ongoing stigma, criminalization, marginalization, just generally the experience of being a person who uses drugs. So that is it for our presentation. Thank you everyone for coming, and yeah, we can see if anyone has any questions.
A question. I wanted to ask about if there was anything that really surprised you when you were doing this research, because you've also been, I know, Marlene, that you've been involved in program delivery as well. Yeah, what surprised you?
Sure. I mean, a lot surprised me. First of all, the willingness to share was exceptional. People were really, really open and excited to participate, which was great. I think the emphasis that people placed not on the prescription medication, but on the feelings of acceptance and community and care, definitely was not surprising, but just, I guess the emphasis was really heartwarming and really nice to see. And I think just really emphasizes that no matter what sort of treatment or what sort of whatever you're doing, working with people who use drugs, you can incorporate that in. It's not Safe Supply specific, right? That feeling of community and connection that can be built into any sort of program. And so I think the importance of that is just so essential. Yeah.
Thank you.
Mm-hmm.
Oh, there is a question in the Q&A.
I can see it. Do you want me to try and answer it? Somebody else?
Actually, it looks like Donna's already answered it. Well done, Donna. Are there any other questions from our audience today?
I can see one or two in the Q&A.
Yeah.
So the first question is, do you look at changes in routes of administration before / during / after, which is not something that, at least I can speak first on mine. For my end, it's not something that we currently had looked at, but it is something that we're looking at for the next reporting period. We discussed, I think either Marlene and Patrick had the idea of looking at the route and the amounts quantitatively that people use at the beginning versus now. So for our next reporting period, at least on my end, that is something that we would be tracking to see how the changes. Marlene, did people mention that in your interviews as well?
Yeah, a couple of people did speak about differences in routes of administration of drugs. So just anecdotally, I had quite a number of the 30 people I spoke with speak about things like, I went from injecting 15 times a day to now I only inject once a day, or I don't inject at all. Or people spoke about kind of exclusively injecting their hydromorphone tabs and then moving to taking them orally. So not something we can speak on very specifically, but anecdotally, yeah, absolutely. Did you find there was a lot of negative feedback in the community? I guess it just depends what you mean by community. If you mean the community, like the people we spoke to of people who use drugs, then no, people are really positive, but I'm thinking you mean the general community, which I mean, I can talk about, but it's not really, no, because we didn't really talk to people in the community for this research.
I can speak about how it's been in our community in general, if you want, Marlene.
Sure, that's great.
Are you able to unshare the screen?
Oh yeah. So.
So I would say that surprisingly, a lot of community organizations or condo boards or environments were pleased with there being an intervention that Safer Supply existed once they understood what it was. I think it was easy to assume Safer Supply was the catalyst for problem behaviors, but I think education overall was really supportive. And once people understood what Safer Supply was, they wanted to have it there.
Great. There's some questions in the chat as well as the Q&A, but I guess I'll keep going with the Q&A questions for now. Okay. Alex, do you mean, do I know why there are barriers to accessing safe supply in institutions? I think that's what she means.
Yeah, she says yes.
Donna, I don't know if Donna wants to touch on this as well. I mean, briefly, I'll say to do safe supply or any sort of program, you need a willing and excited prescriber who is, you know, really understands what harm reduction is really bought into that process and really believes in it, and also has the time to do something like safe supply. And so I think that, you know, from my experience being a nurse, especially being someone who very often would call the jail to try and advocate for people, knowing they wouldn't get safe supply, but hoping I could maybe kind of get something else, either in jail or in the hospitals. It's often just a lot of, there's not prescribers who are willing to do it, but then also a lot of misunderstandings about what the program is about, what it means, and how people do on the programs. So lots of misunderstanding.
Yeah, I would agree with Marlene as well, as somebody who I used to work at the clinics of Safer Supply, currently I work acute care. So now I get to have the perspective of still doing this research while seeing the physicians who may not have any knowledge of Safer Supply in the hospital see our Safer Supply patients. Mm-hmm. And sometimes they see letters. I've seen letters from our clinics in the community come to the hospital with these patients and have literally seen in real time physicians read them and say, ooh, that doesn't seem right. Goodbye. And they just don't understand. So I think there's just there's a big gap in education towards people who are not interested in health, in sort of the Safer Supply version of healthcare, that I think that we need to just fill with the sort of education resources that we're trying to provide.
I think I would just summarize that again by saying, Marlene and Athena, great points. It is a prescribing based program. It starts with a prescriber that gets behind it, and then it goes further into advocacy and education across institutions. And I think that's still what we're battling.
Mm-hmm. Great. The next question is about the biggest differences between OAT, IOT programs and Safe Supply. I mean, I can get into that. I don't know if here is the exact right place to do that. I don't know, Rebecca, do you want me to give a brief answer?
Sure.
I can. Okay.
Yeah, go ahead.
Sure. So in my mind, OAT and IOT are wonderful treatment options for people who use drugs, people who are, looking to be diagnosed with a substance use disorder and then move forward with treating that as a medical disorder. And so that works for some portions of the population. And then Safe Supply to me is much more, it's a public health intervention with a harm reduction approach. So very simply put, it's just about helping people to continue to use drugs, but in a much safer way. And in no way is Safe Supply trying to treat their substance use or treat it as a disorder. It's simply to help them be safer. Yeah.
And maybe Marlene, if you don't mind, I'm just going to add to that as well. I would say OAT or IOT are, as Ryan's saying, treatments for substance use disorder, whereas safer supply is an intervention for the overdose crisis. Two very different lanes. I don't know if that makes sense as well, just to add to Marlene's point.
Yeah, I was gonna chime in there a little bit too with the differences in the goals. Just again, so the goal of safer supply is to reduce the harms related to the unpredictable and highly contaminated, toxic, potent, illegal drug supply. So yeah, different goals.
And all very important programs to have for different people. Yeah.
Yep, definitely.
What changes do you think you will make to your program? Well, I don't work in a clinical program anymore. Yeah, Donna, I don't know, Donna, if you want to speak to this. I mean, I could try, but I don't want to speak on behalf of any of the clinical programs.
Sure. I think the biggest thing that we did is the very first presentations that were given were to the clinical teams that were delivering the program for education, awareness, and also next steps. So we're still at the individual clinic level evaluating the changes we'll make to the program as we grow. But that was the first place that Marlene and Athena delivered this information to get those learnings and to also tweak it. So we definitely plan to listen to it and to adjust accordingly.
What would you say to people who believe that safer supply encourages drug use? Yeah, that's a pretty common thing that we hear. I would say that if you're asking that sort of question, then I think that you're probably framing your perception of people using drugs as a choice, that they have a choice to be using drugs. And unfortunately, and as you could see from the presentation, the people that we're speaking to, they don't have a choice over their drug use. Their tolerance and their drug use is at such a high level that they would not be able to function and wouldn't be able to do anything if they weren't getting opiates. And so it's just a matter of you're going to get it from the toxic illicit drug supply, or you're going to get a prescription. I can understand that, but I think, again, once you recognize that it's not a choice, then it's pretty easy to have it follow that it's not encouraging anyone to use drugs. I hope that makes sense.
I like the comment somebody just made to hop onto that, where it's not about enabling drug use, it's enabling life and saving lives. Like we used to say that at the end of the day, safer supply is about helping people to survive. Like it's just let people live. Like some people's goals are not to get off drugs, but those people still deserve a safe supply of drug use to be able to not have outcomes that are horrible, such as overdosing and passing away. So it's not encouraging people to use, but it is saying those people who are using deserve to use safely. Simple as that.
And Leah, I saw your comment after. I didn't think that you thought that. It's a really good question, and it's really common, I think, especially for the clinical teams to be asked that. I also think it's important to shift our view to it's okay to use drugs. If somebody wants to use drugs and it works well for them, that's great. They have that choice as an adult to make that decision. So even taking away the whole it's not a choice, people can make choices for themselves either way. And I think it's fine. Using drugs is great. So the next two questions about peers, people with lived experience. So within our, yeah.
I think the theoretical and harm reduction approaches that we're discussing here is important. I think the strongest response we have is among the 425 people, 70% decreased or discontinued during the program. Like, we have hard empirical evidence showing this. That's down, right? Add in the people who didn't have any increases, another 16%. You have close to 9 out of 10 people out of a sample of 425 who actually either stayed the same, but most decreased. So it's no longer a point of debate on will it encourage it. We've seen it decrease, right? And we have the numbers and the evidence to support that. So there's a variety of different answers, but one of them is, why do we do this research? It's to show you empirically what are the outcomes that those who are actually doing this day in and day out know is happening, but we've helped quantify and qualify that.
Thanks, Patrick. So when we, as part of our, this research, sorry, was overseen by the research team, but also the Safer Supply Working Group. And yes, there are people with peers and people with lived experience who are part of the working group and who were around and available and helped at all of the different kind of points in time. Particularly when we went to the sites, because we actually physically went to the sites to meet the participants there to make it as low barrier as possible for people to participate. And we had lots of help and support from the peers there. And as for did we have people as part of the research team and interviews, I mean, every single person we spoke to was a person who uses drugs. So yes. And we relied heavily, like I spoke about briefly, the interviews were largely guided by the actual people who were completing them with me. I didn't go into it necessarily with like a checklist of questions other than the survey, but the actual interview was really, really guided and driven by them. And so all of this research is because of them. With this research, I mean, yes, of course, yeah, we have hope for an expansion of safe supply in the city and across the province and across the country. So yes, hopefully.
I think I would just add to that too, to say that Safer Supply continues to teach us about what individuals need.
Yeah.
It's very good. We're learning all the time. I can speak from the Safer Supply Ottawa program. When we first started this program, we were looking at a Safer Supply opiate program, which quickly grew to a Safer Supply stimulant program, which then grew to a Safer Supply stimulant and opiate program, you know, which now is teaching us that we need something specific for fentanyl and teaching us that we need to look at the benzo crisis. So Safer Supply is teaching us the gaps, and we're hoping to respond ongoing in a fluid way and grow and learn from Safer Supply. So I think there's more growth, more learning, more to evolve with this program.
Great.
I think that's so well said, Donna. If I can just add in here, I think one of the things that we're hearing about from the different research findings that are coming out now, evaluation studies like yours, is telling us that we're doing this relationship building with people who use drugs, who have not been accessing social care and healthcare services. And when you're starting to hear and learn what people actually need. Because this safer supply did come from people who use drugs, as you said at the beginning. And yeah, thank you. There's another question from Alexandra.
Yeah, which I think we sort of just answered. The question is, what do you hope for the future of safer supply programming? And are there factors that are salient to the success of the program? It's essentially what we just spoke about, that we're hoping just to continue to meet people's needs, regardless of what they are, like they have from working in the program since, June of, or probably spring of 2020. It was a lot smaller back then. I remember when in Ottawa, at least, we only had 20 participants at the site that I worked at, and now we're tracking 425 and beyond in the next. So like we've been able to see a massive shift in from such a little group of people where we thought, let's see what happens for these individuals, to now being able to have those same people be part of a huge group. And at least in Ottawa, we have people that are accessing other sort of care and those wraparound services and are getting on things like ODSP, attending primary care. Marlene hit on that in her qualitative interviews, where people are now able to essentially have access to that fixing, if you want to call it that, other parts of their life that are important for them. So I think there's a big, room for that in safer supply programming, whereas we start just treating people who use drugs with a safer way to live, then we can start sort of giving them access and facilitating access to other parts of their life that we could make easier with safer supply. So at least that's where I see it going in the future, is just being a conduit to getting all the determinants of health met.
Yeah, I think as well, something that Ottawa, I think does really well, and that will come out in future research, because we have this is just kind of, report is just one small piece of what's to come. I think that what Ottawa does really well is the different types of programs that are offered, to be able to really target different portions of the population with the recognition that different people just need different things. And as for factors that are really important in the success of the program, I think one is that the programs are constantly changing and evolving. Things are absolutely not the same as when they first started. They're completely different, and that's a good thing. Things need to evolve. Like Donna said, based on what people are telling us, if we're doing something wrong, we want to hear about it. We want to fix it. And the participants are really the experts in their care. And so we really rely on them to be honest with us about what's going well and what's not. Yeah, I think that's what I would talk. I mean, there's lots of things that you could talk about with that, but that's what I would talk about.
I was wondering about, this might be a difficult question to answer right here, right now. So that's okay. And that's okay. I was wondering about people who've been on the program for a while. So you've been operating for a couple of years now. And I'm wondering how, for those who are on the program still after a couple of years, how have their needs or changed, or the way of engagement changed in the program compared to people who are just starting out to just beginning on
Rebecca,
Safer Supply?
I'm glad you brought that up, because we did have a slide that was removed about the patients or clients from the beginning of the program as compared to the clients in this period of time with the numbers. And so I'll let Athena and Marlene speak to that, but we did look at that a little bit.
Yeah, at least from the ones that I looked at, what I did is I looked and separated, because I had a similar thought. I thought, I'm curious, I wonder if I check people's start dates on the program and compare the people who started in 2019, 2020 to the people who are starting now. And actually, of say, like the 20 people, for example, that I'm thinking of that were the initial people, 18 out of 20 are still in the program. So we have seen like a lasting effect with those individuals, that they're still on the program and they're still accessing it. What I noticed back when I was working in the clinics is that some of our people who've been on the program for longer will report that the doses aren't enough. Like they reach that stable dose. And I find that the people who, we noticed that there was a larger percentage of people having like the same use month to month when they've been on the program for longer compared to people who are more recently started. And we think it's more so because those people reach a stable dose, where with their Safer Supply and with their street use, that is now their stable dose. That is what they use safely. So we are tracking that, and that is something that we can include in further presentations, because it is an interesting thought of, well, how can we see how it affects those long-term people? We do have starting to have longer-term data now that a couple of years have gone by, but it's an interesting thought and a good thing to track. So thank you for bringing that up.
Yeah,
It also, I was just going to say, it also came up in the program concerns with the restrictive. I find with people who were on the program longer, people are really seeking more independence and more autonomy as they move through the program. So I think it also just speaks to the importance of really designing and changing the program based on each person and how they're doing. So people who are 3 years onto the program and much more stable probably don't need, weekly urine drug screens, like a person maybe who's wondering what they're using and wanting more information.
Yeah, I was wondering about that sort of thing around programming needs.
Definitely.
Is there more need for I don't know, psychosocial programming opportunities, like drop-in programs for people that, they have more time, or they're more interested in getting connected to, I don't know, education and employment or that kind of thing as the longer that they're on. Yeah. Or addressing health issues that they didn't have time to address before, that kind of thing.
Yeah, we've seen I've seen some informal leaders almost emerge, where we've had people ask, hey, like, would we ever be able to rent some space? Because we have some of the clinics in Ottawa have some room. Would we be able to rent space to have essentially like a forum of people who use drugs, who could talk and connect and stuff? So I remember having those sort of conversations. This is, of course, at peak COVID. So it was more difficult than it is now. But I know that is something that the Ottawa group is thinking of working on, where we could have sort of those informal groups maybe perhaps becoming more formal, if we can provide the space for them to sort of give their feedback directly like that. Yeah.
Thank you.
Okay.
Any other things any other things you'd like to leave us with today before we finish off?
I don't think so. I think we covered most of it.
Yeah. Yeah.
No, I'm glad. Thank you, everybody, for coming and for listening and for being interested and involved, and for the work that everyone does here in this group, honestly, across the boards.
I think the only last thing that I would want to say is that, Safer Supply remains a prescribing-based program, and the way that we can help folks stretch their freedoms and stretch their experiences by stretching prescribers. It's difficult for people to travel. It's difficult for people to get out of communities or get away from situations, as long as we keep this, trapped into one area alone. So we hope that we can be mentors, be a network of work with the National Community Safer Supply Network, and be able to educate prescribers and people who have interest to see that this is a very much needed lane, and that there's a body of practice of people doing it, and it can grow, and it can help people further.
So well said. Thank you, Donna. I really appreciate that, because I think that is a big piece for people, especially who have been on the program for a while. We're hearing about people wanting to, move, but they can't move because, there's only a Safer Supply prescriber in their current area, that kind of thing. And so being able to have a wider range of prescribers out there that all work together and can support people to help them live the lives that they want to live without being restricted based on having to stay close to one program or one provider. Yeah, thank you very much. I'm looking at all the, go ahead.
Thank you, Rebecca, for creating the space where we could come and present. We're appreciative to be able to be here today.
Oh, we're so glad to have you here, and it's so great to hear about the program, because you've been going for a good couple of years now, and even before funding came along. So it's really nice to be able to take some time and reflect on where things are at. And we created this research spotlight webinar because we hear people saying like, well, what's the evidence? What's going on? So we really want to, as we say, put the spotlight on what is emerging right now. So it's fantastic to have this program evaluation. This is we have a couple of program evaluations that are out there. So this is joining into a larger body of knowledge that we're getting from different program evaluations, and we'll have more coming up in the series here. So yeah, thanks to each of you for your work, for your willingness to be here, for your presentation. We will be posting this webinar up on our website within the next 24 hours or so. If your team is willing, we'd also love to share your slides if that's okay. And any other, if you have a formal report that's publicly available, we can post that there, or direct people to talk with you, whichever's the best approach. Yeah. Great.
Thanks everyone for coming.
Thank you. And our in December, oh, why don't I have this information right on the tip of my fingers? December 7th, I believe. It's the first Monday in December. We have Stephanie Glegg will be presenting on their work. It's a piece of it's an environmental scan that they did of Safer Supply and IOT programs in Canada. So they'll be coming to talk about that. So there's more coming. And then November 24th, we have our hot topic meeting, which, as Robin talked about at the beginning, was mobile Safer Supply programs. Great. All right, everyone, we'll say thanks and goodbye for this week.